Hi, everyone, and welcome. Thank you all for joining us today. My name is Elizabeth, and I'm with ACRC Global, and I work closely with intended parents exploring surrogacy, egg donation, IVF, and other family building options. Today's webinar will focus on PMOS, fertility treatment, and the different family building paths that may be available to patients as they navigate their reproductive journey. So we're so happy to have Dr. Alexander from Southern California Reproductive Center, or as I call it, SCRC, with us today. Thank you so much for joining us, Dr. Alexander.
Thanks for having me. I love all you help, so it's wonderful.
Yeah, I'm excited to talk about it. And so Dr. Alexander is a board certified in obstetrics and gynecology, as well as reproductive endocrinology and infertility. She has extensive experience in helping patients with fertility preservation, IVF, recurrent pregnancy loss, and conditions such as PMOS, which we'll talk about in more details today. But before getting into that, I'd like to briefly introduce a little bit about ACRC. We were founded in 2015, and our headquarters is in Irvine, California. That's where I am right now. Over the past decade, we've helped more than 1,300 families around the world build their families through surrogacy, egg donation, IVF support, and other assisted reproductive technologies. And our core service include surrogacy programs. We also do egg donation matching, embryo transportation, and IVF concierge services, as well as international family building and support. We work closely with fertility clinics, attorneys, insurance specialists, and case management teams to help intended parents navigate every stage of this complicated journey. And whether someone's just beginning to explore their options, or you are ready to move forward with the next steps in treatment, our goal is to provide guidance, resources, and support every step of the way. And for our intended parents that may be joining us today and are exploring donor options, ACRC also maintains our own egg donor database. This is what it looks like, and we have over 200 donor profiles that are currently available. And you can filter depending on, blood type, education, ethnicity, even there's a little height thing at the bottom that you can use. And all donors complete medical history reviews and genetic carrier screening before becoming available to match. Many of our intended parents begin with IVF using their own eggs, while others eventually do explore egg donation options. And we're here to support both pathways. All right, and now I'd love to introduce you to today's speaker, Dr. Alexander. Again, thank you for being here. And would you mind briefly introducing yourself, sharing a little bit about your background and your personal experience with PMOS and fertility challenges?
Definitely. Thank you again. I'm a fertility specialist and I'm from Los Angeles, but I trained at Johns Hopkins Hospital in Baltimore. And then I was part of Cedars-Sinai for 8 years, and I've been here for almost 12 years at Southern California Reproductive Center. And I've always used our embryology facility here since 2007, which is exciting. My research projects have been a lot about PCOS or PMOS, now polyendocrine metabolic syndrome. So I think, it's interesting that now my other part of my journey has been being an older parent. So I feel like a lot of patients, I resonate with them because I understand what you're going through and the fears and the worries. And I know you guys hold everybody's hands through the process. So it's a special process that we help people through to have a healthy full-term baby, whether it's ourselves carrying or through surrogacy, or if we're having to face the discussion to think about the pros and cons of egg donation. I think I'm really proud of our team here at SCRC. Our nurses are so caring and dedicated. They go above and beyond for all the patients. And our third party team run by Suzanne is like so wonderful and very dedicated. And it's just, I don't have enough kind accolades to say about them, but thank you.
Thank you. And yeah,
Yeah,
shout out to Suzanne. She's very, she's a very hard worker. And your whole team is just awesome to work with.
yeah.
Right. So before we jump into today's discussion, I'd also like to share a special opportunity for everyone today. So on the screen, there is this QR code, and you can schedule a consultation with our ACRC team. And we'll talk a little bit later as well. Towards the end, Dr. Alexander also has a discount for consultations that will also be provided. So stay tuned till the end. But whether you're exploring IVF, egg donation, surrogacy, fertility preservation, or just looking for the next steps, want to chat with us, we're happy to discuss and answer any questions that you have. And like I said, we are offering the exclusive promotion for today's webinar, and we'll share it towards the end. So let's get started with the first official question. All right. So PMOS was previously known as PCOS, and you were involved, you discussed this, involved in the board discussions around the name change. So can you share why this change was important and why what patients should understand about PMOS today?
Definitely. It's a multi-system pathophysiology with no clear causal factors. It's partly genetics, partly endocrine disruptors and environmental factors that kind of cascade into different elements that people feel. And so that's why you may even have cousins or siblings or people that have different symptomatology. And so it's a polyendocrine issue. And the key things is in metabolism and hormone imbalances. Some people have super high androgens or testosterone. Some people have adrenal androgens that are elevated, such as DHEA and DHEAS, that their adrenal gland is producing a heavier amount, causing cystic acne, especially in puberty, sometimes earlier puberty, hair growth where it shouldn't be, such as our chin and neck and between the breasts and sometimes on our tummy line or lower back. And so there's a phenomenon called hirsutism or male pattern hair development. And sometimes that can be familial. And people say, I have this, but my testosterone's totally normal. My periods are regular. So that's a different sort of avenue of different ways that the hormonal issues can pop up. In addition, there's blood pressure issues. We notice some young women have the diastolic level, which is the lower number, be a little elevated above 90. And sometimes that's a smoke signal that there can be a predisposition for chronic hypertension when we're older, as well as it's something called metabolic syndrome, where our lipid panel or cholesterol panel can be altered and have an increased risk for cardiovascular risk when we get older. As well as if we snore, there can be sleep apnea. And then sometimes if your doctor says your liver function levels are borderline, that can be something called NASH, which is where the liver is affected by a metabolic process of fat deposition. And you may not be overweight. That can happen in slim people too. And so it's short-term and long-term sequelae of PMOS. So the short term are the two P's: keep your periods regular and keep a menstrual log. If your periods get spaced out further and further, talk to your OBGYN about what are the options to protect the uterus from any precancer cells or bad cells that can develop. If you're on an IUD and don't get your period, that's different because that's producing progesterone to purposefully not get your period. Or if you're on birth control pills, then some people skip the placebo week or the sugar pill week and they'll skip their period. That's different than naturally skipping our periods. That's kind of like a little mini red flag. The other P is pregnancy. So let's say in the next year, you're thinking to start a family. You might want to get a checkup, check your thyroid, check your vitamin D level, make sure your pap smear is up to date, be as physically fit as possible. Think about nutrition and egg quality. You could read some excellent articles and books on how to improve egg quality, and then monitor your ovulation. Around a third of the time, we do see the male factor where the sperm count, motility, or morphology is borderline. And so it's not always the woman's side, it can be your partner as well. And so it's important to get an annual checkup and get a checkup. And then if we're over age 35, we encourage people to think about trying for about 6 months, then have a discussion with an OBGYN or a fertility doctor. And if we're under age 35 with regular periods, you can try for about a year and then get a checkup unless you're having other health issues like rheumatoid arthritis or psoriasis or other autoimmune issues or health issues that you have to have a bigger discussion and discuss what medications you're on to protect yourself. If you've been on a GLP-1 agonist, it's important to talk to your doctor because it can have ramifications for egg and sperm quality. And so we usually are having a window of time where we have people take a little break from that before they embark on trying to get pregnant.
Yeah, well, thank you so much for that. And I like how you had the different, if you're on your period or if you're taking birth control or not. And I think it really helps people realize that PMOS reflects a broader understanding of how this condition impacts overall like health and fertility. And I know there are so many different factors involved. So thank you for that. Yeah. All right. Let's go to question 2. So, what are some of the biggest misconceptions patients still have about PMOS and fertility in general?
I think it's a little hard when sometimes our patients come in and they're so petrified that it'll be such a high hill to climb to conceive, where sometimes just a little finesse to get people to ovulate and we can help them get pregnant
Yeah.
relatively easily. But it does, even for myself, again, being kind of an older parent, it was this like little fear that feels like a weight on us as people. And so some young girls, they'll go through puberty and the pediatrician might have said, oh, it might be a bit challenging, or your OBGYN might say you have to get a checkup quicker than other people because of the PMOS, which is true. And it's good to optimize inflammation and your overall health. But the misconception is that it'll be like super duper impossible or extremely hard. I think it's important to know all the factors, but it's a discussion. So
Yeah. Yeah, I can imagine like the misconceptions kind of create that unnecessary like fear and confusion. So yeah, that's why it's important to have that first consultation and talk about it. All right. Let's go to question 3. So, for patients with PMOS, what are some of the most important factors you evaluate when creating a fertility treatment plan?
we want to make sure to check on ovulation and the ovarian reserve tests, such as the anti-Müllerian hormone level. We found that if that is extremely high, like above 11, there can be a smoke signal that's a signal of inflammation. And so even though a lot of the time when patients are faced with fertility treatment options, their AMH is low and they're worried for low egg count. With PMOS, we're also a little concerned if the level is too high for the risk of inflammation, as well as the higher risk of gestational diabetes if we're having inflammation too. And so the other piece of the puzzle is, and that was one of the things when you asked a good question on misconception, is sometimes the fallopian tubes, which is how the fallopian tube catches the egg at the distal end of the fallopian tube, occasionally someone may try all these different mechanisms to ovulate and medications, and then lo and behold, the fallopian tubes may or may not be open. And so it's important to strategize on egg quality, inflammation, the fallopian tubes, and of course, the semen analysis. Here we try to encourage it within 6 months, because sometimes if men had COVID or are use vaping or heavy marijuana users, we can suddenly see changes in the semen analysis. And so we kind of have a discussion on that. The other important factors are trying to optimize the body mass index or your nutrition and weight before you get pregnant, because you'll have less risk of anomalies in pregnancy, less risk of gestational diabetes, chronic hypertension, and those types of things. I know for me, I did do the 90 days of really no candy, no sweets. I I put in my mindset kind of that Mediterranean diet. It was hard because sometimes I was like daydreaming of a chocolate chip cookie or something. But then I would just say I've had enough in my whole journey of my life and I enjoyed a lot of things. So now I'll just focus this time window on this. So I had to put that in my mindset, which I know you have wisdom on that too, Elizabeth, as well. But
Yeah. And it's funny you mentioned the fallopian tubes because my parents, they went through IVF when they weren't, they're having problems. And so one of the first things that they checked were my mom's fallopian tubes and they were blocked. So that's yeah. So she had to go through surgery and get them unblocked. But now it's me and my sister. So it worked out. So yeah, that
yeah, I
just,
still am Facebook friends with the first time I re-anastomosed a tube, and when we did that and she got pregnant afterwards. But the fallopian tube, the caliber of the tube is so narrow, it's only like a couple millimeters. So it's microsurgery, so it's a tricky thing. But the fallopian tubes are really magical.
yeah.
Yeah.
All right. Let's go to question 4. All right, so how do you decide when a patient should continue trying naturally versus moving forward with fertility treatment or IVF? And I know it's not, I guess, maybe necessarily 100% your decision, but how do you, talk to intended
Yeah.
parents about that?
I try to get a sense from both partners where they are, what how many kids they want, their family building goals too. So, and then I use the AMH or anti-Müllerian hormone level kind of as a tool, but it's not a perfect test, as well as the day 3 FSH, which is a hormone from your pituitary gland, and estradiol. You want your FSH less than 10 and estradiol 30 to 60 to kind of get a vibe on egg quality as well as how your ovarian function is too. And then if the motility of the sperm is low or the morphology is 0, I never trust one semen analysis. I'll always recheck it and work closely with a male urologist too to have a discussion, because occasionally we'll catch a testicular varicocele or heaven forbid, like a tumor or anything like that. So we want to make sure we're all getting our checkups. And then if the tubes are open or not, too, plays a role in the decision of the treatments. And then I put plan A, plan B, plan C, and we kind of use statistics to decide, and depending on how long the patient's been trying.
Mhm.
So it's many different factors involved too.
Awesome. Yeah, well, thank you for sharing that. All right, and we'll move on to question 5. So you often speak about personalized patient care. So how does individual treatments improve fertility outcomes for patients?
Yeah, I think if our mom or sister had breast cancer, sometimes we have to be a little frugal with the medications because we don't want to cause the estrogen to go too high. If we have a strong family history of blood clotting disorders, we'll double check for factor V Leiden or these genes that can make us more prone to blood clotting issues. So depending on your medical history, if you've ever had surgery, if we had appendicitis, there are times where the right side got inflamed and the tube's not as open on that side. So we'd be more compelled to look into that, especially since it is true as doctors overall, endometriosis kind of flies under the radar sometimes, but we do have a new blood test, which is kind of been pretty fascinating, called HERNOVA, and it's I've been doing it for the last like 2 months, and it's been an interesting tool. It's not a perfect test either, but it's a tool to double check for or endometriosis, or if necessary, more detailed imaging to understand that. Um, so I think definitely family history, we tune into that, as well as our own how we went through puberty. So women who went through earlier puberty, sometimes we have to try to understand their adrenal gland more. If a patient has chronic hypertension, we want it really well regulated before they get pregnant so that they're not on any medications that are harmful to an early pregnancy. And so there's a lot of nuances that seem easy, but they take a little bit of detective work and thought to plan before helping people get pregnant too.
Yeah, actually sitting down and even like with our, egg donors, that's a major thing too, is the family history and like, reviewing that with them as well. And if, like there was any deaths, what caused it. So it's super important.